Hi, everyone. This is Edward Shin, and welcome to the Quality Reviews webcast. I'm the CEO and co-founder of Quality Reviews, and we help health systems and healthcare providers improve patient experience through real-time feedback. And it is my pleasure today to welcome our guest speaker, Dr. Charles Washington. Dr. Washington is Senior Director of Radiation Oncology at Memorial Sloan Kettering Cancer Center. And previously, he was Director of Proton Therapy and Operations at MD Anderson. He is author of the textbook Principles in Radiation Oncology, and now in its fourth edition. And we are going to be talking about Dr. Washington's recent doctoral dissertation. He just got a doctorate in education from the University of Southern California in LA. Go Trojans. So welcome, Dr. Washington.
Was at Wayne State University and was matriculating toward becoming a physician. My dad had contracted lung cancer. And as we were working with his treatment regimen, part of the aspect of his care was inclusive of radiation therapy. And so during his stay in the hospital and throughout the course, I learned a little bit more and more about the practice of radiation therapy. And I really enjoyed seeing the melding of not only the science, but also the social aspect of engagement. So, some of the most fearless people that I know are those that have gone through cancer and have taken the bull by the horn, so to speak, in the overall management of their care. So, people initially have a thought that radiation oncology or the use of ionizing radiation for cancer management or cancer management in general, would be a depressing field. But I found it to be some of the most upbeat, some of the most rewarding engagements that I've ever had. I really enjoyed the patient experience, and I just so happened to be at an institution that offered radiation therapy as a field of study. And so I transferred my credits from the pre-med curriculum to pharmacy and allied health, and then started matriculating in the radiation therapy program there. Graduated, had three job offers. I put three applications out, got three job offers at the time, and I decided to go to MD Anderson Cancer Center, where I could really leverage the uniqueness of having a bachelor's degree within the science itself, because it was you could have a combination to be able to go into practice, either an associate's degree or a hospital-based certificate or a baccalaureate degree. And so that afforded me the opportunity to be a little unique. And the rest is history from there. I started practice at MD Anderson, went there and was a practicing radiation therapist for a number of years, became a program director for the educational program. And that's when I went over to the dark side of the force, so to speak, and went into administration.
Well, I was
Stayed
about
there.
to say your voice is very Darth Vader-esque, so.
So I've been told. From there, I was afforded wonderful opportunities to be able to not only establish myself in practice at the center, but also become very, very engaged in the profession as a whole on the local and national level. I've been blessed to have been able to speak locally, regionally, nationally, and internationally on radiation oncology topics. And then when I retired from Anderson, I moved out to New York, and currently in West Orange, New Jersey, and practicing at Memorial Sloan Kettering.
That's great. Let's fast forward to your doctorate in education. Now you have an MBA, you have all of this education, and here you are saying, I want more education, and you got a doctorate in education. Why did you choose to do that? And then why did you choose this particular topic of service recovery and patient experience?
Sure. In terms of the educational platform, I think that as I was looking at my career, I've had a long career and a lot of experience within the field. And to be able to really increase the longevity of my effectiveness in the field, I thought that it would be prudent to start looking at matriculating in an area that had great interest. And education has really been that underlying love for me. And so, in every aspect of what I do, I lean on that educational platform to be able to move forward. And so, when I looked at what opportunities there were at my institution, there was a lot of thought about change and change management. So, my degree is in organizational change and leadership, which really afforded me the opportunity to leverage the wealth of leadership experience that I've had, the practical experience, as well as validate that and then learn new aspects to be able to now afford me an opportunity to go into different avenues and really increase the overall effectiveness of the timeline that I have in terms of practice itself. So it was an investment. It was an investment in continuing to maintain a level of relevance, as well as being able to continue to make an impact on the profession.
Got it.
Regarding the dissertation topic, that's a little bit of a story, because when I first came into the educational program, I was going to write my dissertation on how the patient experience, how I can change the patient experience, which is just too broad. One of the first things they teach you in doctoral programs is to take those broad thoughts and really hone it into an area that you can really get your arms around, so that you can be impactful on what you can do. So I was looking at my practice at Memorial Sloan Kettering, and with that practice, I noticed that with the wealth of experience that I've had, and but more so looking at the overall effectiveness that we have had as an institution, as a practice in managing cancer, there was still opportunities for improvement, and that was along the lines of the patient satisfaction. You know, it's not uncommon to have patients come in from times gone by that would come in, listen to what the physician has to say, do exactly what they have to say, and it doesn't matter how their experience is as long as you get the outcome. Well, Memorial gets the outcomes. It does a fantastic job in overall effectiveness of its cancer management, but we could do better. So when you start looking at the Press Ganey scores, those benchmark scores of how we rate as a department, comparing ourselves to our own institution platform, to our other like hospitals, there were areas of improvement that we saw. So in discussions with the leadership of the institution, we saw an opportunity to dovetail some of the overarching goals that the institution had to impact the patient experience to radiation oncology specifically. We had already started working with the quality reviews tool in terms of looking at getting some real time patient feedback. And so thought about, how can I leverage what we already have in place and start looking at how we can make that experience better for the patient overall. Because at the end of the day, patients are like any other consumer, particularly younger patients today. They come in with expectations, and every facility that you go into needs to do two things. They need to afford the patient the best opportunity to be able to have cure if it can be achieved, or quality of life, which should be attainable in itself by all, and to be able to make sure that that patient's experience in receipt of that care is really top notch, and that you not only meet the expectations but exceed it. So that's when we start delving into, how do we make sure that we leverage information that we can get from the patient so that we can make it better for them. We already were doing the outcomes were already fantastic, but it became more and more focused now on how do we make that experience better.
Yeah, interesting. I mean, it's almost like Memorial is doing the hard part, right?
Yeah,
Treating cancer, getting good outcomes, and then you're like this patient experience part. It's like, hang on, there's a lot of common sense here that, we need to be implementing. Having said that, let's dive right into your dissertation. Can you just give us an overview, kind of like an outline,
it's sure.
and maybe just touch upon the highlights, and in particular, what are some of the things that you learned from your own research that were surprising to you?
Oh, Ed, I don't know if we have enough time to go through all of that, but I will do my best to keep focused. First and foremost, it's really important to understand what service recovery is. Service recovery is an opportunity for conversion. Conversion of what? Conversion of a patient's experience that may not meet their expectations and give them the opportunity to feel better about the experience itself. And so, as we know, there's a lot of things that can go wrong in a very complex environment. Some of the things that we've learned through the use of our quality reviews tool is that our patients sometimes have challenges with wait times, how long it takes them to wait. They come in, they come on time, and then for one reason or another, they're not able to be serviced at the time that they expect, or that their explanation of what the care is going to be about, um, they may not fully understand. And when you talk to practitioners, it's interesting because I know that practitioners do a very good job of providing patients with information about the management of their disease, but patients come in and they are often overwhelmed, oftentimes so overwhelmed that they don't remember. And so those types of things come out. So a myriad of different types of experiences are shared with us, and we want to be able to then impact it. And so what we did with this particular study was to look at several specific questions and really keep it very tightly focused, and we chose as the stakeholders as being the management team. So you may ask, why the management team? The research, the literature tells us very distinctly that the impact of the managers on frontline practitioners' understanding and their engagement level is critical to the overall receipt of the expected outcome. And that becomes a challenge because, in as is the case in most healthcare arenas, frontline practitioners are extremely busy. They are extremely focused on what they're doing, but they have 100 different things going on at the same time. Sometimes that focus is not there, and sometimes when the manager, in trying to meet those core expectations, may not invest as much time. And we'll talk a little bit about some of the outcomes of the study that we found to be very interesting and serve as opportunities. But we looked specifically the uh, at service recovery practice. We set a standard that said we want our patients to be serviced with a service recovery phone call within 24 hours of receipt of their complaint, so to speak. So we use a 5-point Likert scale, with one being extremely dissatisfied and five being extremely satisfied. So if we received a score of 3, 2, or 1 on any aspect of the questions that were shared with us, that would prompt an opportunity for us to contact that patient directly by one of our manager teams. And and what we found with that expectation, we did a lot of upfront work in setting up opportunities for training. We set up a lot of opportunities for um, being able to have documents and guides and things like that, policies and procedures written. But what we ended up finding was that we were doing a very, very dismal job of getting to the patients within 24 hours. Now, we would get to them within 48 hours or 72 hours, but not the expected for 24 hours. And we wanted to know why. Maybe it was too taxing. Maybe there wasn't enough resources. Maybe people didn't understand. The default oftentimes when people don't meet expectations is training is typically the answer. And what I can share with you that the research shows that the number one reason why people oftentimes don't meet their expectations is not because of knowledge base, it's because of motivation. And that's a totally different beast to deal with. So we were finding that our outcomes were low around for that expectation of 16% of the patients that were eligible for intervention within 24 hours were not getting, only 16%. So we said we need to understand why and what went into it. And so that's where we devised the study to be able to look at the impact. And the study is an explanatory sequential mixed methodology study. What does all that mean? That means that it takes into account not only the value, each a quantitative study, provides you with objective data, very, very objective. Qualitative information gives you depth. Each one has its own limitations in its own right. And so what we opted to do was do a mixed method, and that was to do both. That way, when we get information, we can triangulate it in a way to be able to ensure that the entire breadth as well as depth of the problem of our practice was being assessed. Does that make sense?
Yeah, absolutely.
And so that's where we embarked upon to be able to get that. So we try to understand in this mixed methodology method, we try to understand and set up tools to be able to help us with the assessment. The first tool was a godsend, and that was being able to utilize secondary data. Secondary data, of course, is utilizing data that has already been collected, but distant to the initial intent. And so one of the things that the quality reviews tool was able to provide us was not only information on what patients were saying about the things that were bothering them, but it also gave us timestamps in terms of when the complaint came in and when it was serviced. And so when looking at that, we reviewed over 7,000 points of data to be able to make assessment quantitatively, excuse me, of what was going on here. And looking that at 775, I believe, bits and pieces of data that really could bear that overall assessment in a finite time frame. And so that gave us a very solid baseline that told us that we were not meeting the expectations. It was not anecdotal, it was proven. We were able to discern and have data that showed that there was an opportunity. The second piece that was quantitative in nature was a survey that we devised. And the survey looked at asking the frontline managers questions about their understanding that assessed knowledge, that assessed their motivation as well as the organizational structure. So Clark and Estes in 2008 outlined a gap analysis formulation that helps to look at current state versus expected state and be able to then do some interventions in light of what's going on there. And so that being the case, we were able to discern overall that the managers understood didactically what service recovery was. They asked, yes, I know what to do when a patient, I know what the trigger points are, all of these things. They knew about it, but they did not put it into practice. And so that gave us opportunity to think there that it was time to really make assessment. And so we worked collectively to gather the knowledge data, the motivation data, as well as the organizational influence data to really look at how we move things forward. So again, those two tools that were quantitative, the secondary data that was uh, collected by way of the quality reviews tool, and the survey that we had done provided us quantitatively what that baseline was. Then we looked qualitatively, and we looked at two sources of data qualitatively. The first being documents and artifacts. And so the documents and artifacts we looked at and did a scouring of any notes, any policies, any procedures, any handouts, anything that we had that had to do with service recovery, and made an assessment of, of when they were produced, how they were being used, and what value they were perceived to have. So that gives us an outline of what was documented. And what we found was that while we had a lot of data that was done up front, we were not reporting out on what was happening along the way. And so we did that. And then we had what I found to be some of the most interesting aspects of the study, and that was the interview series. We had 15 managers that were accessible. And of those 15, 12 of them did respond to the survey and provided us with data. And we may think that, wow, 15, 12, that's a low number. The important point to remember is that when you're collecting data and you're looking at it, particularly in qualitative data review, it's important to reach a point of saturation. And that saturation means that those findings, those things that you're coming across within the data set that you have, it continues to reinforce what you've already seen along the way. And you're not getting a lot of brand new bits of information. So we reached that point. People were saying the same things, and they were saying the same things in a way that ultimately gave us insight that while there was understanding of what to do, there were challenges in getting it done. And some of the big things that we saw was within the motivational realms. I think this is a good point, Ed, if I could share my screen.
Yeah, absolutely.
There's a couple of charts that I think may be helpful
Yeah.
along the way.
And while Charles is doing that, folks, feel free to write any questions you have for Charles in the chat box or in the Q&A box. So feel free to type in your questions as we go along.
So what we see here is just the purpose, just outline the purpose of the project. Like I said, an explanatory sequential mixed methodology where you have objective measurement as well as depth of meaning for the study. We wanted to do the gap analysis to see how effective service recovery was, specifically within our target group, look at the quality of the interventions that would help to transition patient dissatisfaction into more positive experiences, and then focus on the challenge that's created in those frontline management knowledge, skills, and organizational influences. So this is kind of like the reason why do we do this. And so we ended up with 3 research questions that we answered that this data set that I had just shared with you spoke directly to. The first one, to what degree is radiation oncology meeting its goal of providing 100% of service recovery within 24 hours for that period of time? What is the knowledge and motivation? And then what are the organizational challenges that we see combining those two, those last two? So each of those goals were able to be answered directly by the formulation and the triangulation of the data that was received. it's very important to note that within this particular realm, we found congruence. One of the things that researchers need to be very mindful of, particularly young researchers, is the positionality of the researcher. I have over 35 years of experience in radiation oncology, and so I've seen and experienced most things, but that does not mean that all of my assumptions are always the truth. And it's important to challenge ourselves. And that's one of the most difficult things for researchers to do, is to understand and realize their own internal and personal biases, to be able to make sure that those things that we held as truth are challenged. And that's why, if people really rigorously reflect on things that are presented to them, the process is not easy. Reflection is a very, very rigorous process whereby we challenge ourselves. And it's easy to not challenge ourselves, and we take things from our experiences as being, it is what it is. But that's not always the case. And we found this out in this study.
Yeah.
And so the data, as I was mentioning, here is a reflection of the data with the advantages and disadvantages of each one. The secondary data, the survey, the documents and artifacts, and the interview itself. And then you can see the numbers of each one and the sampling size. Again, don't be fooled by the small numbers. You oftentimes will see small numbers, particularly in qualitative components of studies. It's really about that point of saturation and making sure that there is a level of confidence in the data that you have there. So just moving forward, this is what we found after assessing all of those components. And you can see I'm going to break it down into what we found out about knowledge, what we found out about motivation, and what we found out about the organizational influences. And so there were three knowledge domains that we assessed. And we found that there was a gap between what we thought and what our priority was, in terms of the frontline management team needs to know the trigger points. And so there's some citations that shows what should occur. It's important in carrying out an operation to have the ability to command basic understanding. And then what do we do about it? We provide information sheets. So in the knowledge realm, we provided and saw the need for enhancement of the cheat sheets, the job aids, and those type of things that would be reminders. So you place things up in the department to remind people of what the expectations are. Here's one of those areas where the frontline management team needs to understand the link between service recovery, patient engagement, and patient satisfaction. Was it validated as a gap? This was Charles Washington's assumption that there would be, and there wasn't one. There was congruence there, that they did understand these things up front. And so that was an area, while we cited it, it wasn't necessarily a priority for us to explore. The frontline management team needs to know how to engage patients. During this recovery, there was a gap there. Again, having job aids and things of those nature. Now, the knowledge base, again, is what people oftentimes default to when there's a problem in practice. And there's a series of books by Stolovich that have been out for a bit of time, but they're very, very interesting. And the titles of them are Telling Ain't Training, and Training Ain't Performance.
Right.
I'm not making that up. The idea there is that just by us telling somebody one thing or another is not adequate to be deemed as training. There has to be checks and balances. There has to be assessment. One of the things that we saw here in this study was that we had the need for reinforcement and more feedback in terms of metrics and in terms of engagement that was going to allow the people to be able to really embrace what we wanted them to embrace. So those two components had really been helpful in really some of my earlier formulation of understanding that knowledge itself is not oftentimes the means to address problems. The next piece is, though, the motivation influencers. And here there were two areas that I'll touch upon: goal orientation, and where you make assessment of a person's rationale, their internal rationale for wanting to get things done, how they set goals. And one of the things that I really focused on while I saw a gap really was a little different than what I had initially expected. You know, again, I was projecting in some aspects that said, what I like to do is make sure that I master something, that I really get into understanding something fully, and so that I can perform it well. And I get pleasure in making sure that my expected outcome is being reached. What we oftentimes found that the motivation that people had was not necessarily trying to get to mastery, but more along the lines of trying to meet specific reward opportunities. And so that causes you to shift things and build in opportunities to kind of tease what really gets people moving. Remember that motivation is internal to the person. It's influenced by their experiences, their life experiences, their professional experiences, not so much what I tell them to do directly. That goes to the second piece of interest. What type of interest does a person have in there? And there's two types of interest that we can assess. The first is situational interest. Situational interest is when you are given a task, there is an expectation that you're going to get something done, and there is a direction and a reward and an endpoint. You go to the next one. The internal motivations are those things that you really like doing, and you want to do these things, and your interest is coming from within. So you've got an external motivation for situational and an internal motivation for intrinsic types of interest. The hope is that as we continue to do a better job in explaining things to individuals, that you really get involved with having an opportunity to get them moving into a direction that converts that situational interest into a more intrinsic type. But in this area, we saw the need to have more efforts in giving them problems to solve, and look at how do you tease out their self-improvement opportunities, more engagement, more educational um, interfaces, either through synchronous or asynchronous means. So the motivation piece becomes very, very intricately a part of the overall process. And the last piece that we made assessment of was the organization. Two things there: the culture as well as the setting. The culture says we value action orientation. We value your ability to do things proactively. There's some urgency. We value the urgency in trying to get to the bottoms of things. The cultural setting is, on the other hand, making sure that the resources that are needed to be able to get the job done are available. You ever seen a scenario where a job expectation is set out and you don't have enough people to do it, or you don't have enough supplies to do some things? That's what the cultural setting makes assessment of. Are we doing those things? And so there needed to be more. We saw gaps, and we needed to do more along these lines to make sure that expectations, valuation is all in place. So all of these things collectively gave us the opportunity to really synthesize some opportunities overall. And with that, we utilized another model, the Kirkpatrick and Kirkpatrick New World model. Their initial modeling talked about going from one, which is level one, what is the reaction? Do people like it? Do they feel that the training or the intervention or the process was relevant to them? Were they satisfied with it? And then moving on to their learning. If they're satisfied, if we got that satisfaction, then um, let's go to the learning. Do we have opportunity for skills? Then how did that manifest itself in terms of their behavior? And lastly, how does it look like in terms of results? That's what it originally was. The new world model takes it backwards because the primary focus in most businesses is results. What are the results? So you start there and then you work backwards. And we were able to do that within the confines of the program. And what we walked away with in a general terms was the fact that we needed to do a better job in making the outcomes and expectations known. We had to do a better job in making sure that the resources were in place. We had to give people engagement information. We had to make sure that they had metrics so that they can monitor things along the way. All of this being said, at the completion of the study, we came away with these are the things that we needed to do. Now, fast forward to where we are today. That 16% of engagement now is at over 95% engagement and 95% compliance with what our expectations are consistently. I think that the data now is been consistent for well over 7 months. But it took our interventions that were found during the study itself to really be impactful for the practice itself to really make sure that it had the opportunity to do this. So, the take home messages from the whole thing is that the patient expectations itself are critical, but it's also as critical to make sure that the team has a very clear understanding of the value of the service recovery, of what it impacts there, because everything is never going to be perfect all the time. But what we can do is make sure that the patients get this feeling that their challenges matter and it's done in a quick fashion. We have had some patients come back anecdotally and say, you know what? I just sent this survey in and I had no idea that I was going to get a call back. And I really appreciate it. What happens now though? We continue to monitor, we continue to do this. We now want to be able to see how we can utilize the tools that we have, the practice that we have, and correlate that with a multivariate analysis to see if the interventions that we have can not only impact our ability for the patients to receive an intervention quickly, but does it have an impact on the overall scoring of those benchmarked Press Ganey scores. So a lot more to come. So it's like the never-ending story. So you find one answer and you find 5, 10 different ways of applying it to be able to answer more and more questions. And
Great.
so in a nutshell, that's pretty much where we've come about, how we've come about.
That's great. That's phenomenal. Thank you for sharing. I have a quick question. So that's 16% pre, and
Yes,
then now you're at 95% post.
yes,
So 16% of the time you were doing service recovery within the 24-hour period.
right,
Someone was calling the patient back. Now it's almost 100%.
almost.
What are, you know, to kind of bring it to the real world here
Yes.
for people on the audience members, what are some practical measures you took to get that 16% to 95%? And as you said, influencing the extrinsic motivation as well as influencing the frontline manager's intrinsic motivation.
I think that the main thing was making sure that the expectations were very clear. And again, it's one thing going back to the Stolovich, telling ain't training. You've got to be able to have a very methodical and very well documented practice in terms of how you utilize the information, and you have to be able to be very consistent. That's one of the things that we were very good up front, but we were not consistent in giving feedback along the way, and it just sort of drifted with everybody kind of half looking at it for a period of time. And then when we really started engaging in it, because we really wanted to be able to make an impact on some of the patient experience itself, that's when we said, you know what, we've got to do a better job with this. And so what we did was we had weekly reports. We gave the managers feedback on their team in terms of how they were providing. And it wasn't an attempt to be very draconian or such. It was more along the lines of, here's information. Here's where we have an opportunity to do better. And it's interesting because a lot of people oftentimes relate to the Hawthorne effect. If somebody's watching you, you'll get the results that you're looking for. But what really occurs is now that it's become part of the practice. We were able to look at that situational interest because they had to do it. And now it's a matter, because when you start looking at the data that came through from the managers' interviews, they took a lot of pride in when they were able to do it, but they were not consistent with it. And so we saw that there was an opportunity to engage them more. So I think that's the biggest take home, making sure that you're consistent in how you engage your people, you value them, you reward them appropriately, and you have an opportunity then to continue and build upon those successes. People like it when you give them a pat on the back and you're successful, because ultimately that's going to help them in cementing in that the job is well done and it's appreciated. It's one thing to be well done, but it's better to be well done and appreciated.
Got it. Some questions from the audience. First, from Troy. When it comes to quality care for patients, how do you manage the blind spots that may come when it comes to care for patients of color?
Oh, that's a very, very good question. Being able to be mindful of practice, so quality care it should be colorblind. And number one is access. And there's a lot of work that is currently being done across the country to be able to have access, because it is not unknown that oftentimes individuals of color may not have the same levels of access, be it because of fear, be it because of opportunities for insurance and coverage along those lines, be it because of misunderstandings, particularly along the research lines within the communities of color. There's a big disparity between what we think is the right thing to do and what people fear. And so being able to ensure that is to continually talk, to be able to continue to have opportunity to engage people face forward. Um, and I think that along those lines, and making sure that the practice itself is consistent across the board, is the way that we have to be able to ensure that. But access is huge. And
Yeah,
that's something that we need to continue to work on.
yeah, absolutely. This is more pertinent than ever before. Absolutely. Another
Absolutely.
question from Edison. Can you share the survey for managers? After this, would it be okay if we shared the questions that you were asking your frontline managers?
Oh,
Um,
certainly. It's
okay.
published in the dissertation.
Okay.
So
All
all
right.
you would need to do is to go online and look up. I would do a Google search on Charles Washington plus addressing service recovery, something along those lines, and it will come right up.
Okay.
And I have made it accessible to any and all people that would like to
All
see.
right. We'll make that available to the audience members. The other question, part of the question is, what are the metrics to measure success of a service recovery program?
The metrics that's a very, very good question. And one of the things that you can look at is the ability for us to have fewer instances. And so it's not only a matter of intervening. The other piece of this that we didn't talk a lot about is making sure that those causative factors that got the people to complain are addressed. So what we're doing now is looking at all of the interventions that we have put into place, And we're also calibrating that against the number of service recovery opportunities we have across the board. And so we're taking some measurements now to be able to see if that aggregate number is starting to go down in respect to the number of patients that we are seeing. During the COVID practice, we've seen a decline in the number of patients overall. It's starting to come back up now, but so we saw lower numbers during that period, and now they're starting to come back up. So that's one metric, and the other is going to be looking at that multivariate analysis to see what direct correlations there can be with service recovery intervention and Press-Ganey score, since that is the benchmarked tool that we use. But the thing here is that Press-Ganey is interesting in that while it is an accepted, well subscribed tool, it does make its assessment several weeks or so after the fact. The nice thing about the tool that we use for this period of assessment for service recovery is that it's near real time. And so when the patient gets the survey within a couple of hours at the completion of their appointment, they're getting a survey, and we're asking them to send it back to us, and then it starts the process, and then the clock starts ticking, and we get it from there.
Got it. Another
That's
question
been a
from,
really great thing.
yeah, thank you. Thank you for that. Another question from Lorene. Dr. Washington, did any of this training happen with frontline staff to empower/train them with service recovery skills to work through the dissatisfaction as soon as possible with patients rather than managers only?
Oh, absolutely. Yes. And so part of the expectation was having, number one, the managers be assessed in this study. Again, remember, it's multifaceted, and the choice for this particular study was looking at the intervention with the manager because they are going to be the conduit for the frontline practitioner. And so, yes, the frontline practitioners got all of that data and all of that information up front, and now the success of it is being touted with them as well. And so the expectation is that as a practice, we want to be able to intervene. And beyond what we do with service recovery, the institution does have very formalized practices for those frontline managers. Frontline practitioners, the radiation therapists, the administrative assistants, all of them have had education and expectations to be able to address patients directly as they encounter them. In the radiation therapist educational process, patient engagement is a huge part of it.
Got it. Another question from Khadija. How often was the feedback provided to the managers? And was there a standardized way to plan the improvement, or was it based on each clinical setting or unit?
That's a good question. No, so we try to keep it as standard as possible. Now, in my setting, we have 6 different sites, and so we try to make it consistent all across the board in terms of expectations as well as feedback. And so initially, the feedback when it was at a low level was more sporadic. We had to do a better job of providing information. And now the feedback is provided on a weekly basis. And we've been very, very consistent. I don't think that there has been any occasions when we have missed a week. And so there is constant feedback. And it's really nice when I go back in and say, we've done 95%, we've done 98%, we've done 3%, whatever the number is. It's very, very high. And we offer the appreciation there. So I hope that answers the question.
Yeah, I think so. Let's take a step back. Memorial Sloan Kettering, obviously world-renowned
Yeah.
institution. Give us a sense of the size of the radiation oncology enterprise at Memorial Sloan Kettering. You said 6 different locations.
6 different
Yeah.
locations
How many
that
patients is that?
absolutely, that span 2 sites in Manhattan for radiation oncology specifically. 2 sites in Manhattan, 1 in Westchester, and 3 sites in New Jersey. And so we have those sites that are geographically spread out. We also have um, partnership affiliations with other facilities as well that are not as direct. But we have 6 directly focused areas for radiation therapy, equating out to I think we right currently have 30 linear accelerators. We have 9 simulators, CT-based simulators, PET CTs, MR Linacs, MRCTs. One of the nice things about the size and the scope of a Memorial Sloan Kettering is that state-of-the-art equipment is absolutely there. And a lot of times, in comparison to some of the more small community settings, taking nothing away from the level of care and the caliber of care that people get there. Um, but we see and treat numbers of patients that are upwards of, over 12,500 new patients each year.
Yeah, that's a lot. That's a lot.
Yeah.
Another question, follow-up question from Khadija. How have you managed service recovery for radiation when Linacs go down for whatever reason?
Remember what I said initially. You can't always uh, address the downtime and things like that. But what we can do is make sure that we communicate to the patients. What happens oftentimes with patients getting upset when there's machine downtime is that we don't communicate effectively with them because we're running around doing this, that, or the other thing to try to take one patient from this area to another area. What we need to make sure that we do a good job of is making sure the patient is engaged. So in our facilities, we also have uh, bulletin boards that don't speak to patient information, but unit information, that if it's on time, if it's not. So making sure that patients are communicated with at the most, outside of 25 minutes. If they have to wait longer, we need to be engaging, or we invite them to make sure they come and see us. But I think that that's what we need to do, is make sure that they know that we appreciate and value their time. A lot of times we get so practitioner and institutionally focused that we are not patient focused, and that's the take home. Patient focused care, that means that when they have problems, we address it.
Right. Something very simple, but kind of we have to remind ourselves of that.
Absolutely.
Just running up on time, just 5 more minutes,
Yes.
but we've been talking about cancer and radiation therapy. Obviously, over the last 12 months, we've been in the midst of a pandemic.
Yes.
How has your practice of radiation therapy been influenced and changed during this past year? So many things going on. Patients, even in the best of times, cancer patients are vulnerable. You throw on a life-threatening virus on top of that,
Yes.
and cancer care can't be done virtually. So give us just an overview of how you guys have adjusted to this new normal.
Absolutely. So we've learned a lot in terms of, I was one of those individuals that would have thought that a frontline practitioner like a radiation therapist could not be effective remotely. And I've learned new things because there are aspects of the practice that can be done remotely. And to be able to protect the workforce, we went into and devised schemas where half of the patients, now you had fewer patients come through, and so we were able to reduce the workforce where half work from home, looking at some of those more clerically focused areas of practice, while other half were on site with with all of the PPE and such, and then they would rotate out. And so you're keeping your workforce fresh. That way, if you had practitioners, and we have had practitioners that have come down with the virus, you are not debilitating yourself to the point where you're not going to be able to continue to offer care. So that aspect, as well as from a non-delivery aspect, being able to engage patients with telemedicine has been a huge effort. We've been doing a lot with that, and we just put out a paper that looked at surveying the patients because we wanted to see in radiation oncology what was the patient's perception of a telemedicine visit? Did they think that it was as effective as not? And what we found in that paper was that the patients did not see any discernible difference for the most part between a telehealth visit and an in-person. Now, we all have our preferences, but there was nothing statistically significantly different about the two, which is huge, which means that as we move forward, our practice can incorporate more of this to be able to now have access increased by just doing some certain things. So we had to pivot. And I believe that the department has done an extremely good job of that. And we've learned new things, and the new norm is that we can do business in a remote setting, and we can do it as effectively as we have done before.
That's great. One final question. You mentioned some stories of patients submitting the feedback and then
Yes.
getting a call back and being completely surprised in a pleasant way. Can you offer another story or anecdote of where, a service recovery callback kind of made the difference? Any kind of stories that
Oh,
stick out in your mind?
there's plenty of those, because as I noted before, patients can be very distraught, especially initially when they come in and they have a diagnosis of cancer, and they're strongly managing everything, but it's difficult, it's hard. And just being able to I've had several patients come back and say that, number one, the engagement with the practitioners on a very personal level. They come in thinking that the practitioner is going to be the experts in the delivery of care, which they are. But the other piece of that is that engagement. Particularly with the radiation therapist, they see the patient every day, and that serves as a big resource for them. And we have seen comments that have been nothing short of glowing for the appreciation that is expressed to the team. I've seen it given to physicians, to nurses, to radiation therapists, to clerks, everyone, the whole team, and it makes a difference. It makes something that can be very dismal. It makes it palatable, and dare I say, at the end of treatment, when they're ready to ring that bell 3 times well, it's a celebration, because that course it has been done, and people have impacted their lives. One of the things, my final note will be, I remember a time when patients had commented on and thanked us for giving them more birthdays, for
Yeah.
allowing them to have more birthdays.
Amen to that.
Yes.
Yeah. Amen to that. Well, on that great positive note, thank you so much, Dr. Washington.
You're
Thank you
more
to
than
the
welcome.
audience for joining us for this whole hour. I learned a lot. We'd like to do this again, if you don't mind, Dr. Washington, as
Oh,
you do
anytime
some
that I
more
can be of
research.
assistance,
Yeah.
I'm happy to share.
And we'll make the questions available, the Frontline Manager survey questions available in a
Yeah.
follow-up email to the audience participants. But thank you. Thank
Thank
you to
you.
the audience. Be well, please be safe, and we'll talk to you soon.
All right. Take care now.
Thanks, everybody.
Mhm.
Bye.